Hurry. I can see you, boss. Okay, good evening, everybody. I'm delighted and honored to have the faculty during this lecture. So I'll start from, are you all ready? Signed in?
Yes, sir. Yes, sir.
Okay. So can you start, Athengi? Can we start?
Yes, sir.
Okay. So I just had some, I think you mute your audio, the voice response. I just want to clarify a few things. There were little doubts yesterday, so I'm just telling you the classification. This was published in the Survey of Ophthalmology. Then in ophthalmology, the Beckman's initiative. So we call there is no disease when there are no drusen's or pigments. Okay. The normal aging, there are drusen's, but they are small drusen's. They're hard drusen's. And if it is early, then there are drusen's which are soft drusen's, but they are less than 125 micron, and there are no pigmentary changes. Okay. Then intermediate drusen's. So intermediate disease, that is when there are large drusen's and or pigmentary changes. So there can be only large drusen's, or there can be only pigmentary changes, or both can be there. And advanced disease is one when there is a CNV or there is geographic atrophy. They are not mentioned whether it involves fovea or not, but it usually involves fovea. Okay. Now the ARADS study done 2 times in 2001 and 2006, they had 4 categories. So I have just told you, I have just mentioned what it corresponds to the classification. So you can see this normal or no aging is category 1. So it's same definition, few hard drusen's only. Early is category 2 where there are few intermediate drusen's, okay, and there are no retinal pigment changes actually. And then intermediate is one in which there are extensive intermediate drusen or at least one large drusen, okay. And there is geographic atrophy not involving the fovea. Advanced disease is one where geographic atrophy involves fovea or there are features of neovascular disease. This is one very important clinical tool which ARDS has given us. So see this carefully, this graph. So see the right eye. If there is large drusen's or even one is there, you put yes, then put score 1. And pigment changes are either pigment atrophy or pigmentary clumps. I showed you some clumps, okay. So if it is there, you put 1 score. So the right eye has maximum of 2 scores. You got this point? And left eye has same, it has got 2. So maximum person can have is 4 score of 4 by both eyes. So what they did, they plotted over 10 years. If his score is 1 at baseline and how much chance he is having developing the disease, and if it is 4, how much he is having chance. So you can see 0, 1, 2, 3, 4, 5, 4. You can see that the one with the 4 has the highest chance of advanced disease, means he will develop CNV or fovea involving atrophy of the geographic atrophy. Are you getting? Are you hearing me? Okay. So, and whereas those.
Yes, sir.
Okay. So those who are in, I think one of you just unmute, others you can just, whenever I ask question, you can do that. Okay. So if there are only 3 points, only 27% is over 5 years. But if you go to the 10 years graph here, there's this one, okay, cursor, you can see that almost up to 60% or 65% will go to advanced AMD, and if the score is less number of patients will go to advanced AMD. Okay, so these are the conclusions, and this is the treatment I talked about. Every patient who has this score of intermediate disease, they should receive this treatment indefinitely, and they should give health history. Now we'll go to the neovascular AMD. This is what usually is the presentation. And symptoms are metamorphosis is a very important symptom. They will come of crooked vision or decreased vision if there is blood, so that the vision will definitely reduce. And if there is a slow leakage from the CNV under the retina, there can be gradual decrease of vision. So patients may come off with scotoma also. I told you how the scotoma looks yesterday because of bleeding under the retina, or sometimes it can be asymptomatic. See this case. So this patient, I saw she was being treated for left AMD, active AMD. In July 19, we did her OCT, absolutely normal. Can you see some drusen's, large drusen's here? She was susceptible. Now see, in September 19, during examination, she did not complain anything. But when I examined, I found that there is retina was elevated here. There was something hazy here. When I did OCT, you can see that there is subretinal fluid and there is some subretinal exudative material. So definitely she needed injection. So sometimes they can be asymptomatic or they may not realize that they have the growth. So wet AMD is...
Sir, the voice is breaking in between.
I think I got a message that my internet is not very good. So actually I have dongle of Geo, but still I don't know. So you may have to bear, whenever it breaks too much, you let me know. Okay?
Yes, sir.
Okay, the wet AMD or neovascular AMD is characterized by growth of the new vessels. They grow from, you can see this diagram, they grow from the chorea capillaries, they grow through the Brooks membrane, and they reach the sub-RPE space. This is the sub-RPE space. So buds of neovascular tissue, they also are accompanied by fibrovascular, fibrous tissue also, fibroblasts also. Now the neovascular, choroidal neovascular membranes or vessels, they are classified into type 2 or type 1 and type 2. There are other types also, we'll come to that later. Type 1 is known as occult because we cannot see it on fundus picture or also on the fluorescent. It's mainly a fluorescent angiogram definition. The fibrovascular complex proliferates between the basement membrane of the RPE and inner collagen layer of the Brooks membrane. This is what it is actually. So this is the basement membrane of the, where is my cursor? Okay, this is the basement membrane of the RPE and this is the Brooks membrane. The vessels are growing in this place. So if the vessels are restricted to this space, we call it as occult choroidal neovascular membrane or type 1 choroidal neovascular membrane. Okay, what it does is it may alter the normal architecture of Brooks membrane and RPE, and it may cause visual loss. Okay, what happens once it grows there, because the vessels, I told these vessels are not normal vessels, they leak a lot because chorea capillaris access, they leak. So they leak under the RPE, causing RPE detachment. The fluid may detach the RPE. The fluid may accumulate under the RPE, lifting it up, and it can bleed also. The RBCs can escape into the sub-RPE space, and there can be a subretinal sub-RPE bleed, or there can be frank hemorrhagic RPE detachment. Sometimes the fluid may go through the RPE if the RPE is sick. You know, the journal occludents, they may not be very efficient in these patients. So they may allow fluid to pass from the sub-RPE space into the subretinal space, causing a serous retinal detachment. And that can be clinical or sometimes seen only on OCT. Then sometimes the sub-RPE blood, if it is profuse, it may break through the RPE into the subretinal space, and sometimes even retina can be torn and you can have a subhyaloid hemorrhage or vitreous hemorrhage. The fiber, if it is not treated, sometimes it may lead to slow fibrous scarring and the end stage is disciform scar. So the type 2 is when the choroidal vessels, the choriocapillaris vessels, they go through the RPE and they come under the sensory retina. These are the photoreceptors. So they occupy the space between the RPE and the photoreceptors. So when they occupy this space, we can clinically see them as reddish branching vessels. Sometimes we may see, or sometimes a grayish red membrane we may see. This is called as type 2 CNV. So this is a type 1 CNV where it is below the RPE, and type 2 CNV when it has grown through the RPE into the subretinal space. So this, you can see that this patient has a RPE detachment, and you can see some hyperreflectivity. This is probably a choroidal neovascular membrane, and you can see some fluid here, and this has caused some fluid in the retina also, and you can see that the ellipsoid zone is missing over this detached retina. So probably patient will have some disturbed vision in this area if you do microperimetry. So what are the signs of wet AMD? We saw the symptoms. Now what are the signs? The signs are that if there is a serous retinal detachment, the patient will have a shallow retinal elevation, but these will be indistinct borders. If there is a serous RPE detachment, it is more well marked and elevated, round or oval shaped, and it's probably little darker. And sometimes, like this patient, see, you cannot. This is actually RP detachment, but it's a very small RP, shallow RP detachment. So you cannot make out in this fundus photograph. Can you make out? You cannot make out anything in actually. Okay, but if there is a very high elevation of the RP, then you can see very well demarcated round elevation of the RP. So sometimes there can be irregular elevation, the one we saw fibrovascular RP detachment, and sometimes there can be hemorrhagic RP detachment because there will be hemorrhage into the RP, and sometimes subretinal blood can appear, which is bright red, and subretinal or intraretinal lipids are also common because if there is a subretinal or sub-RP CNV, they can leak proteins or lipids and they can accumulate in the retina or subretinal space. So you can see this is an extreme case. Actually, it's already a disciform scar is there and he has blood under the retina. You can see it's a bright red blood and some part is actually some darkish, so there must be some sub-RP blood also. Now you can see this patient. Can you see this blood? Thin layer of film of blood. So this is actually subretinal blood, very thin. And you can see that there is hardly any elevation of the fovea, but she had diminution of vision. She had 6/12 vision, but she had noticed that. You can see that this is a RP elevation, and you can see that there is subretinal, sub-neurosensory retinal detachment hyperreflectivity corresponding to the blood here. So this causes the this has blood into the subretinal space. And I told you there can be hard exudates. You can see that there is hard exudates around this area of RP detachment. You can see, and it's not very clearly seen because he had cataract also. So you can see that he has a lot of hard exudates. So intraretinal hard exudates can be not only seen in other vascular disorders, but it can also be seen in AMD, and it has some significance. Other signs are sometimes can be subretinal pigment ring and subretinal gray-white lesion. I will show some examples. And sometimes if there is chronic leakage, it may enter the retina. It can cause cystoid macular edema. Then CFAN pattern off. You can actually see the subretinal new blood vessels. So that is CFAN pattern, that is type 2. And sometimes if there is a large RP, it can break and it can cause RP rip. So that is another sign. It's the end. Actually, it's a very unfavorable sign of wet AMD. And the end stage we will see is disciform scar. So you can see that we are seeing actually a grayish membrane under the retina, and you can also see some blood. And if we do a fluorescent, I'll show that fluorescent angiogram later. Okay. Now there is type 3 CNV. We saw sub-RP lesion, that is type 1, that is occult. Then sub-sensory retinal choroidal nephron membrane, so that is type 2. So that's called classic lesion on fluorescent angiogram. There is one more called type 3. So this is called retinal angiomatous proliferation or RAP lesion, and this is characterized by intraretinal hemorrhages. Then exudates. Actually, the new vessels start in the retina and they start growing towards the subretinal space, then towards the sub-RPE space. We'll discuss about it later a little more. So the diagnosis in wet AMD is straightforward in most cases who are appropriate age, but there are some differential diagnoses like IJFT in what is that, some idiopathic lesions or histoplasmosis or choroiditis lesions. So there are many cases, but most of the times when a patient about 60 years comes, he has drusen's and he has this wet AMD, it's very straightforward. The investigations are fundus fluorescent angiogram. OCT is mostly replacing fluorescent angiogram. OCT angiography, if you have, it's a non-invasive imaging of the vascular pathology, but the cost is very prohibitive. And ICG is useful in occult choroidal nephron membrane, and also in another type of AMD called as IPCV, the ICG should be used. Now, use of fluorescein is we diagnose, it's the gold standard, and we can also see the location of the choroidal nephron membrane, its extent, and we can follow it after a treatment whether it's regressing or not. And the earliest frame when the leakage starts defines what it is, type 1 or type 2. Each type is evaluated for presence, proximity to the center of the macula to classify it. Okay, the classic CNV or type 2 CNV, how is it seen? It is seen as well demarcated area of intense hyperfluorescence, and it has lacy pattern and it slowly leaks, progressive leakage. And later the anything? Okay, fluorescein is most intense at the perimeter of the CNV, but at the just outside the CNV, you will see hypofluorescence, usually because there is small leakage of blood or pigments. The center may show hypofluorescence because there may be fibrosis. The vessels might have been replaced by fibrosis. It is seen actually in minority of AMD. And many times occult component is also present. So in a fluorescent angiogram, it is very rare to see only classic. Usually it is also associated with occult choroidal membrane. So in this patient, in Kuwait I had this patient. So you can see that he had phaco 1 year ago and his vision was excellent. But he came with the anything?
Audio bantilla. Adu off ittu nodi adu.
Hello? Kertidea?
Yeah.
Okay. So this patient came with disturbed vision. Please call later. Okay. So, but we saw some gray elevation here. Can you see, appreciate this gray elevation? Can you all of you appreciate this gray elevation?
Yes, sir.
Okay.
Yes, sir.
Yeah. Okay. Then we did his OCT, and you can see that there is subretinal hyperreflectivity, and you can see that there is a subretinal fluid. This fluid was not very visible, but we could make out definitely that there is a grayish elevation here, grayish or a little darkish elevation here. We did fluorescent angiogram. You can see that this is a classic CNV pattern. Classic CNV pattern. You can see that there is lacy pattern, and you see that the edge of the is very intense, and you can see that it's surrounded by a small area of hypofluorescence. This is due to either pigments or some exudates or some blood actually. But you can also see that there is punctate hyperfluorescence all around here. So there was actually occult choroidal membrane also in this patient. In another patient, you can see a grayish membrane, and you can see a very frank red blood here, and there are some large drusen's here in the retina. And see the fluorescent angiogram. You can see that this is a lacy pattern, and the blood, what does fluorescent it do? Actually, it is blocking the choroidal fluorescence. See, the retinal vessels are seen crossing over the blood, but the choroidal fluorescence is not seen. So this is actually sub-retinal blood. And you can see this fluorescence. This is above this blood, so it is probably subretinal choroidal membrane. Please come later. Okay, sorry about that. So this is another case. You can see that the lacy pattern starts early because the choroidal membrane, the classic type 2, comes from choroidal vessels. It starts filling up along with the choroidal vasculature. So, and it becomes intense. You can see that this is mainly classic, but unfortunately it is subfoveal. You can also see a small rim of hypofluorescence due to either blood or exudates. Another case, you can see subretinal blood. You can see classic lacy pattern of very well defined, well demarcated. In early stage it starts, and it's surrounded by blood. You can see on this one also. In the classic CNV, we should measure the CNV in early frame because the borders will be blurred by later leakage. And we classify them as subfoveal if it is under the fovea, the third picture, and juxtafoveal if it is outside the fovea. The center is at least one micron away from the center of the fovea and up to 200 microns. And extrafoveal, it is beyond 200 microns. I told this about this. The occult CNV is seen in two forms. Occult CNV is below the RP. You know that? Again, I just want to remind you, it's below the RP. There are two forms. One is fibrovascular pigment epithelial detachment. Another is late leakage of undetermined origin. So actually what we see is irregular elevation of the RPE, and in the fluorescence we see stippled or granular irregular fluorescence is seen, usually about 1 to 2 minutes after dye injection. And we should still stereoangiogram, which you don't have, and the progressive leakage occurs and stippled hyperfluorescence becomes more, but it doesn't become as intense as in classic. So you can see that there is hyperfluorescence here, but you cannot make out a well-defined lacy network here. There is stippled appearance of the choroidal membrane. So this is a classic, this is a very nice example of occult choroidal membrane. This is another example where you can see that there is a lacy pattern here, but there is also stippled hyperfluorescence here. So it is both. You can see the lacy pattern. Can you see this lacy pattern? Can you see this lacy pattern? And there is stippled hyperfluorescence here. So both can be present together. Combined forms. This is another case of occult choroidal membrane. So you can see that actually in this case there is almost a disciform scar, but you can see that there is subretinal neovascular network actually with blood. And when you see fluorescent angiogram, you can see a leafy pattern like flower type fluorescence is there. There are punctate hyperfluorescence in other parts, so indicating there is occult fluorescence, this one. Okay, so this chart actually just summarizes them. I'll upload this in the YouTube. You can see. Now angiographic subtypes. Classic has they actually further divide when there are mixed. Actually, they say classic subtype, in which the classic part is more than 50% of the coronal membrane. Okay, and minimally classic means it is only 1 to 50%, and rest of it is formed by the occult part. And occult with no classic means there is no classic component. All the lesion is occult actually. Now this is the RP rib. This patient had actually a very tense RP detachment, and she received anti-VEGF treatment, and the RP suddenly it breaks off and it crumbles. It is crumpled here, and this is bare RP actually. And if you do fluorescent angiogram, you get hyperfluorescence here. And this is the end result of AMD if you don't treat. Okay, it's another case where there is actually a very atrophy as well as a fibrosis there under the retina. This is another case of disciform scar. Please call later. Hello? Anybody? Amel Matar. Okay. So the one thing. Yes, anything?
Dr. Wani.
Yes, please.
Yeah. Hello, I am Dr. Arvind here.
Ahead.
Can I interrupt you, or shall I talk at the last?
No.
No, this classical CNVM, how do you differentiate from a myopic maculopathy and this thing? This is for the postgraduates. Clinically, how do you differentiate?
Myopic maculopathy will occur in the myopes only, of course, in high myopes. And that the fundus is macular lesion. There will be no drusen's. And most of the time, this blood is very small. Okay, they don't bleed very this one. And these patients are definitely younger. And most of these lesions are classic. They are not occult. And most of the times they are associated with hemorrhage. They are covered by blood. So if fluorescent angiogram you may not get, you may have to do ICG, and you may do a OCT that may show some fluid. Okay. So, but mostly the age, myopia, and absence of drusen's, it differentiate. And fugue spot. Sometimes there can be break in the Brooks membrane with blood without a coronal membrane. So sometimes it's very difficult.
Okay.
You have to do ICG in those patients.
Okay.
So
right.
I'll go ahead. Okay. Most angiographic lesions are subfoveal and occult. Okay. So you can see that they're not treatable by laser. Only 20% of the lesions are subfoveal, and approximately half of juxtafoveal and extrafoveal lesions are predominantly classic. Now, what is the use of differentiating whether it is occult or classic? Let me tell you, whatever discussion I gave you has become almost obsolete now, but we have to know, okay, because this was mainly for the macular photocoagulation study and if you want to do laser. But right now, whether it is, and for PDT treatment, photodynamic therapy, this is also almost obsolete, okay? So most of the times anti-VEGF acts both against occult as well as classic. So the classification is not very important, but from the point of view of theory, you should know this. Now coming to another investigation, OCT, it's one of the most indispensable investigation in the AMD, and it is non-invasive. It detects subretinal fluid, intraretinal fluid, and location of the CNV, and it helps to monitor the response of the patient to treatment. So most of the trials of AMD involve OCT. They will give injection and see every month whether it's responding or not. What are the features? Intraretinal cyst, subretinal fluid, RP detachment, subretinal blood, and subretinal tissue. And there are other signs like onion layer signs, and there are some other chronic signs. But anyway, so you can see that this much of subretinal fluid I will definitely miss in clinical. Okay, so see the small subretinal fluid, and this is subretinal tissue. What is this? So only 10 minutes remain. Please, I hope I'll finish. This is if I run out of time, I will actually sign out. Then again start a meeting, and all of you join, please. Okay.
Okay.
Okay. Oh, now this is another case where is the pigment epithelial detachment is seen here, and there is subretinal tissue. This is actually fibrous scar tissue, or it may be blood. or it may be thick choroidal neoscleral membrane tissue. And this is a patient with, you can see a subtle, this will not be seen clinically whether what it is. So you can see that there is subtle RP detachment, and you can see there is some hyperreflectivity below, and this is a choroidal membrane which is leaking, and this leakage has caused a subretinal fluid, and this patient definitely needs treatment. This is another case, the same case, she has hemorrhage here in the center. You can see if you do fluorescence, OCT, you can see that there is RP detachment, and this blood is seen, and definitely there is some small areas of subretinal fluid also, and this lady definitely needs treatment. And the same lady, after receiving 3-4 injections, there was some delay. You can see that it is still actually active, or it has become active again. She had responded. Vision had recovered 6/6, but again she has leaking. You can see that there is subretinal fluid, and there is still RPE detachment. This is another case where there is a fibrovascular RPE detachment. You can see that there is a sub-RPE. This is RPE detachment. See, this is the RPE. You can see it is elevated here, and it's again elevated here, again elevated here. And this small line is Brooks membrane. Can you see the small line? All of you?
Yeah.
Yeah, this is a Brooks membrane.
Yes, sir.
Yeah, here also you can see there's a Brooks membrane, and there is a lot of hyperreflective tissue under the RPE, and this is all actually choroidal membrane. So this is called as fibrovascular pigment epithelial detachment because there is hyperreflectivity under the RPE detachment. Whereas in this particular one, you don't see any hyperreflectivity, rather it is dark. So there is only water, means there is only serous RPE detachment, and you can see that. But there is some choroidal membrane somewhere it is leaking. Oh, this is a very complex presentation, and the treatment is very difficult in these patients to give or not, because there is so much tense. This one, if you give, they may develop RPE rip. So another case of this one, you can see this patient. If you see the fundus, you will see something is here. You can see this the other banana shaped, the rather orange lesion here. Can you see this? You will see that. But if you do OCT, you can see that there is RP elevation, there is sub RP hyperreflectivity, and there is subretinal fluid. What is this? What is this layer? Any PG? I've been always telling this. What is the bright line here above this dark space? Anybody? Someone?
Ellipsoid.
Very good. This is the ellipsoid zone. Okay. So you can see that ellipsoid zone is undergoing atrophy here over the RP detachment because the nutrition becomes less. Slowly they undergo atrophy. This is the other eye of the same patient who has already advanced AMD. So if you don't treat this patient regularly, he will go into the same stage. Okay. Now OCT angiography, I'll just for theory sake, you should know, this is done without giving any injection. It actually, because it samples the tissue so many times and it uses an algorithm, then it comes to show the vessels of the retina at various levels. So you can see the choroidal neoscleral network. Can you see this? Which is marked by yellow dot red line. So the choroidal neoscleral network is, and this is the RP actually. You can see that sub-RP fluid. This is actually the OCT. Okay. And this is a fluorescent angiogram of the same lesion. You can see that there is a hyperfluorescence here, but it's mainly of occult variety. You can see that actually it's punctate hyperfluorescence. Now ICG has some advantages because it uses infrared wavelength, so it penetrates RP and choroid. So it can be used in occult choroidal membrane or poorly defined choroidal membrane, and it can also be done where exudates are there or hemorrhages are there, and you can distinguish serous from vascularized portions of the fibroscular PD, and it's also useful in a variety of AMD known as IPC. Now coming to treatment, we have the following options: laser ablation. There was a macular photocoagulation in 1990s. I used to do this. We don't use no more. It's obsolete. Photodynamic therapy, vertoporphyrin injection is there because the visual gains were not much. It has been abandoned, but it's used in only some.
Very costly also.
Okay. Then intravitreal injection of.
It was costly also. Yeah.
Costly also. Yeah. It's mostly in the recalcitrant cases. We are not using anymore. So the intravitreal injection of anti-VEGF is the mainstay of treatment. So some people combine photodynamic therapy with anti-VEGF. Sometimes they also combine steroids. There is surgical treatment of CNV. Now we use rarely, and antioxidants to protect the other eye should be started, and low visual aids in case of poor vision and end stage. So when you start your treatment, your question paper answer, treatment of AMD, you write all these points, then you discuss each point, whatever this one. So laser ablation I will not discuss much because it will become obsolete. Okay, now then photodynamic therapy. I'll tell few words about photodynamic therapy. Photodynamic therapy was the first treatment that was shown to be effective in AMD because macular photocoagulation was not very effective. But it also does not improve vision. So what do? Is they inject a dye called vertoporphyrin, 6 milligram per kg body weight, and it's a light activated compound. It is picked up by the vascular membranes, which are dividing cells. Then what we do is we irradiate that CNV area by a diode laser, and the drug molecules are, when they're stimulated by laser, they produce molecules and then destroy the choroidal membrane. So this is this was proved in the TAP study and VIP study, and they showed that, but it was effective only for predominantly classic or only occult lesions. So in between lesions, they did not respond well. Okay, and retreatments are needed every 3 months. The results were no visual improvement, but there was maintenance of vision. About 4% of patients lost vision, and it needs special laser. Only few centers in Karnataka, there's only one center, so it's not used. So the side effects are transient visual disturbances. There are side effects to the injection and photosensitive reactions, and infusion-related low back pain can occur. Steroid injection is also obsolete. I will not discuss. I'll go to the mainstay of treatment, anti-VEGFs. You should know that we discussed that in pathogenesis, that CNV occurs mainly due to upregulation of the VEGF. Okay. And presently they have become, they are effective in all types. This is very important. So we no need to crack our brains, classic or occult, and all locations, it's very effective. And patient with neovascular AMD show improvement in vision. This was never seen with the earlier treatment. They should maintain vision. But if the patient is 612, with treatment, patient can go to 6.6 in these cases. 660, they can go to 612 also. This was shown for the first time with this one. So for example, this case, we have been treating still actually. So she came with 612 vision. She's maintaining 6.9 to 6.6 vision so far. She has received about 14 injections. Now what about VEGF? VEGF is the vascular endothelial growth factor. It's a cytokine. It has 4 isoforms. This is for your theory: 121, 165, 189, 206. 165 is the most important. Okay, and because the pegaptenib, one molecule, which was the first molecule, it was active only against 165. It was not very effective against CNV because all these molecules had to be suppressed. Whereas ranibizumab, bevacizumab, aflibercept, they attack all 121, 165. All these isoforms of VEGF are attacked by the available ones. Macugen I will not discuss. Ranibizumab is known as Accentrix in India, Lucentis in abroad. Bevacizumab, Avastin. Aflibercept is called as VEGF trap. And then the recent one in 2019-21 was approved for Grosulizumab. Okay, many others are in the pipeline. So pegaptenib. So now this gives a rough idea about these molecules. Bevacizumab is a monoclonal antibody. It acts against all VEGF isoforms, and its molecular weight is so much. You can see that it is both. This is the upper part, is the hand-like portion is the antibody portion, and this is the complement portion or complement portion. This is the vertical one. Ranibizumab, we can see that it only takes this antibody portion. It cuts off the FC portion, so it claims that it does not penetrate the eye and goes into systemic circulation. The aflibercept is something novel. What they did is, it's not an antibody. Actually, what this red and green, these are actually the VEGF receptors. So VEGF molecule has to bind to cells through receptors. Hello? So
hello.
Yeah, okay. Another minute I may go off. I'll sign again. You can join it actually. Okay. So
thank you.
Okay. So then you can see that this is actually the red one is the receptor 2 on domain 1 of receptor 2, and the domain 2 of receptor 1, and the green one is domain 3 of receptor 2. There are 2 receptors for VEGF. So they have taken those, copied those receptors and put on this molecule. So the VEGF molecule thinks that these are the receptors on the cells, and they do that. Okay. Okay. So this is the